Yeah. Hello, everyone. I welcome you to the today's session of IVF and Icsi, brought to you by Apollo Fertility. To speak on this topic, I would like to welcome Dr. Alicia Reddy. She is our in-house fertility consultant with Banjara Hills Center in Hyderabad. To give a brief background about our doctor, she's done her MS and fellowship in fertility, masters in training in the reproductive medicine from Hometown University, London. And she's going to speak about a topic of IVF and Icsi, and she's going to throw some light about what exactly it is, when to be used, and so on. We welcome you, doctor, to this session, and we are looking forward to hear from you. So
Sure.
this is all yours, ma'am.
Yeah. Thank you. Good afternoon, everyone. This is Dr. Alicia Reddy. I work at Apollo Fertility, Banjara Hills, Hyderabad. So, in the previous few sessions, many of you were very inquisitive to know about IVF-6C, though it's a common topic, but you wanted a little more light, and especially for non-medicos, they were really keen in knowing that what all we do, and then is it safe to go for it, and what are the indications, and so I just thought a small talk could help you. So what is IVF-ICSI? IVF is in vitro fertilization, and ICSI is intracytoplasmic sperm insemination. These are the assisted reproductive treatment procedures in which the eggs are fertilized outside the body. IVF-ICSI involves a series of steps which we're going to discuss in detail one by one, which takes over several weeks. Um, and then, okay, what are the indications? The first and foremost, what are the indications of IVF-ICSI? It could be if a woman, most common indication, if a woman has any problem with the fallopian tubes, or if the tubes are blocked or damaged, this is the best method to go for. If they have any ovulatory disorders in which they were not able to conceive through normal medication or through IUI or simpler techniques, then women with endometriosis or adenomyosis, where women who have severe pelvic adhesions, they individuals with any genetic disorders, because in IVF-ICSI we also have an option of pre-genetic screening. So again, that can help you if you had multiple abortions before, if you had recurrent pregnancy loss or any genetic disorder in the previous pregnancies, or if you or your husband is a carrier of something. So if you want to check the embryos beforehand to know if the baby is going to get any of those disorders, and we can select the embryo which doesn't have any of those in place inside you. And then also comes the male factor. The male factor could be either oligozoospermia, that is less number of the count is less, if the motility is less, if the morphology is less, so we can choose the method of IVF-ICSI in these patients. Also in azoospermia, where the count is showing nil, there is something known as we can do TISA to the husband, that is the biopsy, testicular biopsy, and see if there are any sperms which can be used for ICSI. So that is one of the major indications. And in some patients with failed other medication or failed IUI cycles and prolonged married life, and those can also be taken for IVF-ICSI. And then in unexplained infertility, the majorly where we can't find any cause and they are not conceiving. So yeah. And then the success rate. Now the success rate totally depends on the age mainly, on the ovarian reserve, how much of ovarian reserve does she have, on the count of the husband, and mainly the specific reason of infertility. In case of unexplained infertility and all, the chances would be a little more of the success rate if the patient is a little more younger, if they have good number of eggs, because also the quality of eggs could be much better in younger generation or younger patients. So yeah, the success rate totally depends on the other factors, right? So now let's discuss about IVF-ICSI step by step. First of all, we need to counsel the patient. We need to tell them in detail what are they going to undergo, because it's not a simple method. Too many injections get into it. I shall let you know that how many days of injections and all. So you need to counsel them physically, mentally, emotionally, to be strong for it. So the first and foremost thing would be the counseling, and then explain them the steps which we're going to discuss in detail. uh, Also, the financial counseling is a part where they need to understand that how much money is going to go in, and the success rate along with it. So yeah, for them, because unlike in foreign countries where it is funded by the government, in India there are very few insurance companies which cover it. So most of them have to put it from their pocket. And yeah, irrespective of the socioeconomic status, we can't make much of changes in the stimulation or the procedure. So you need to give them financial counseling also. Again, you need to take care of their BMI. If the BMI is more, then they really have to lose weight to fetch the good results and to get good success rate. Also, the blood workup is very, very important. In the blood workup, definitely the routines like the sugars, the blood hemoglobin has to be normal, and then the hormones, as much as the hormones are balanced, better the results. You need to check if like simple things like IgG rubella, if that is negative, you need to vaccinate the patient. And then obviously the virology, because there are too many lives involved in it, just not the doctors, the sister, the staff, the embryologist, the OT technicians. So the group D, so you really have to check the virologies. Mainly thyroid, prolactin, and the hormones. If there is any difference in that, you need to control them beforehand, before we start the procedure or before we start the month of the stimulation. So this would be a pre-workup, I would say. So basically, the consents have to be done again, because both the husband and wife have to agree to the terms. They need to give the consent. So consent, counseling, and checklist are the main priorities before we start the IVF. Now, in the month of IVF, see what are we going to do? The first and foremost thing would be on a day 2 or day 3, or day 1 or day 2 specifically, we ask the patient to come for the scan. And in the scan, when we do the scan, we see how many follicles are available in both the ovaries, hoping that there is no cyst. If there is cyst, then that's not the best cycle to go for the IVF Icsi. So we see the number of follicles, and if they are of the same range, and there are not too many disparity in the sizes of the follicles. So first and foremost thing is that. Next, we start with the stimulation. What is stimulation? Stimulation, ovaries are stimulated with medication to promote the growth of follicles containing the eggs. So, on a day to day 3, the follicles are as little as, I would say, 5, it can range from 3 to 8 mm. The best size 3 to 8 mm, and we see that most of the follicles are synchronous. So that when we are giving the stimulating hormones, the stimulating injections, then they all are growing together, so that there is not too much of disparity when the eggs are ready to mature, or the follicles are ready to mature, and when we are ready for retrieval. The drugs which can be used for stimulations, most commonly used drugs are either recombinant FSH or HMG. Um, those are the most commonly used drugs. It's totally on the blood test and the scan findings, and patient's BMI, patient's age, the type of drug, and the quantity of it would be decided by the doctor on that very day. So on a day 2, when we do the scan and when we give the blood test, on a day 3, we review all of those and accordingly start a protocol. So they can be a multiple protocol. It can be a long protocol. Uh, in the long protocol, the injections are started on day 21. Like if this is the cycle, the prior cycle, day 21, the injections are started. In an antagonist protocol, this very month on a day 2, day 3, the injections are started. And as we do the blood tests and the scans, we decide to start the antagonist in between. And there are some kind of minimal stimulation protocols. If the ovarian reserve is really less, and then we feel too much of injection can't help them, also we need to see the financial, then there is something known as minimal stimulation protocol which we follow. These are the protocols. Now, how do we see the response? Because we are going to give injections almost from, if we starting on day 3, the injections go up to 8 to 11 days, I would say. Uh, Minimum of 9 to 11 days. That's how we see here. Or some people do take a little more time, so they give injections further also. So because we are giving so many injections, so we monitor the follicles via ultrasound. Also, we monitor the hormones via blood test, which will give us an idea about the response of the ovaries to the stimulation. Yeah, first of all, we can control the size of the follicle growth, even the quantity. Quality won't be known, but the quantity of the follicles which are growing. So these are the most important things. Again, now to assess the final maturation of the egg or loosening of the egg from the follicle wall, we give a trigger injection. The trigger injection is again decided by the fertility specialist. So when they are doing the scans, they know when most of the follicles have come up to a good range, and when we feel that they are ready for the retrieval and for the maturation, on that day we give one trigger injection. That could be either plain HCG or recombinant or negonist. So that is decided uh, on the day of trigger, that what drug and what dosage are we using. So now, after this, once we have given the trigger injection, after 35 to 38 hours, again depending on the patient, the protocol we use, and the number of eggs we have, and the cause of fertility. So depending on all of that, after 35 to 38 hours of the trigger, we plan for the retrieval. Now, what is oocyte retrieval or ovum pickup? Some people call it OCR, or some people call it OPU, some people just say egg retrieval. Okay, so now this is a procedure which is done under anesthesia. So the patient is totally sedated. She can't feel any pain or anything. Totally sedated. There won't be any incisions. Basically, in a transvaginal ultrasound probe, we put another, there's an aspiration needle which we attach to the probe, and vaginally we retrieve the eggs. Okay, so when we retrieve the eggs, so basically from the each follicle we get certain liquid form in the test tubes. In that, the follicular fluid, under the microscope, the embryologist will check the number of eggs. So we retrieve all the eggs from the ovaries, and under the ultrasound, the further thing is seen by the embryologist. Now, the fertilization. For fertilization, the sperm selection is done by the embryologist. The motile sperms are prepared and selected for the insemination. Again, now the egg maturity assessment. So egg maturity assessment is usually done after 1 to 2 hours of the retrieval. So in this, the cumulus cells surrounding the eggs are removed by a gentle enzyme, so the maturity of the eggs can be clearly observed. Genetically mature eggs can be are usually M2s, which can be inseminated using Icsi. So insemination involves injection of a single sperm directly into the matured egg. So here there are many doubts. Some people ask what is the difference between IVF and IVF and Icsi. In case of only IVF, what we do is we leave the oocytes and sperm in the petri dish, and then we want them to fertilize on their own. But in case of Icsi, the particular sperm is injected directly into a matured egg. Uh, so that is that is the difference. Now the fertilization. Now dishes are placed in the incubator and checked for the fertilization after 16 to 18 hours of the insemination. All right. Now we have to culture the embryos. The embryos are grown into in the lab. So the embryos are usually viewed between day 3 and day 5. So few of them prefer a day 3 transfer, but day 5 is known to be one of the best blastocyst transfer, where the success rate is quite up there. So usually doctors prefer a blastocyst transfer, but yeah, again, that is doctor to doctor, as I told you, patient to patient, and the quality of the embryos, the number of cells seen, the embryologist, the fertility specialist, your doctor, along with the whole team, takes a call to transfer a day 3 or a day 5 embryo. Also, the embryo transfer just doesn't depend on this. It is also your hormones. If your progesterone level is normal, how your estrogen is. In case of PCOD people, that is polycystic ovarian disease, and if there were more number of eggs. There were more number of follicular growth, and if it was hyperstimulated or the estrogen was very high, then they prefer to freeze all the embryos and do a frozen embryo transfer. In case your LHE2P4 is normal, LH is luteinizing hormone, your estrogen, your progesterone levels are normal, your endometrium is good, and you don't have much of changes in the endometrium, it is good, and also the embryos are good, then they plan a fresh transfer. So in embryo transfer, what do you choose? The embryo, which has to be transferred. Generally, people prefer 1-2 of the embryos to be transferred, not more, because it might result into multiple births. 1 to 2 are the basic number of embryos we are transferring these days, especially in India. So embryo is chosen for the transfer. It is loaded in the transfer catheter, and very gently under the ultrasound guidance. There won't be any anesthesia given. It is not painful at all. It is just like one IUI procedure or a very small procedure where the speculum is placed and the cervix is cleared. The embryologist will load the embryo in the transfer catheter to you. Under the ultrasound guidance, we pass the catheter via cervix and place it in the uterus. Very gently release it. So that is the embryo transfer. Now, so many of you ask me, why do we freeze the rest of the embryos? So it depends again on the quality of the embryo, also the number of embryos we are left with. So if at all we have transferred only 1 or 2 embryos and we are left with another 6 to 7 set of embryos, we definitely don't want to discard it. If you don't conceive this time, then the next time you have more chances and you don't have to undergo all the injections, all the pain, and even like financially or physically, you don't want to get distressed. So the rest of the embryos are frozen. But the frozen embryos, the embryo quality has to be really good. Then only, suppose we plan to eat an apple. Only if the apple is of a good quality, you can place it in the fridge and have it the next day. Otherwise, it doesn't make sense. So the same way, the embryos have to be of good quality, and we know that they're gonna survive it. So we place it in the we plan for the freezing. And now vitrification. Good quality embryos that are not transferred are frozen and stored. Frozen embryos can be used subsequent cycle if it was not successful this time. Also for a sibling pregnancy. Yeah. Now what happens after the embryo transfer? There is the luteal phase, which is also known as a 2-week waiting period between the embryo transfer and the pregnancy test. That is again a very important period because we have a lot of queries on that as well, and people are petrified. They're really scared, but I really want to tell you that the stress is a very major aspect of fertility. So lesser the stress, more the chances of conceiving. After the embryo transfer, immobilization or not, again, that's doctor to doctor and place to place, it differs. But then what we suggest is take a bed rest for your mental peace also for next at least 2 to 3 days. And then after that, then also you can do your routine work. It's not that you have to just be stuck on your bed. You can do your routine work. You can go around, but not too much of heavy weights, not too much of taking steps, not too much of traveling. we would ask you to stay as comfortable as you can and as strong as you can. In the injections in the luteal phase, we do introduce a few adjuvants. Also, the progesterone injections, which are very important for the support of pregnancy, and the regular folic acid and all will be going on. So after 2 weeks, you a date would be given to you after the embryo transfer. That also doctor decides that after so many days, the urine pregnancy test has to be done, followed by beta HCG, and then if it's positive, then we plan for the scan and rest of it. And then if it's negative, unfortunately, then we ask you to stop all the medication. And if you are ready with your embryos, like as I told you, the few of the embryos were frozen, so suppose you are still left with some more embryos, then we plan to transfer them and prepare a fresh prepare the endometrium the next cycle for the transfer. Now the risks involved. All right. So one is the ovarian hyperstimulation. Though we take utmost care of giving you the right dosage, there is still slight chances of a more number recruitment of more number of follicles and than expected. Then there's slight chances of ovarian hyperstimulation. That is one more topic I would like to discuss in our next video, where we want to tell you that how do we know about it and how can we control it. But these days, thanks to the medical advances and the doctors and their experiences, they know how to manage with that. But obviously precaution is better than cure, so we always try not to reach there. Multiple pregnancies is another risk factor, because the baby weight, the delivery, everything differs if you have multiple pregnancy at the same time, be it twins or triplets. Again, we have seen in a very slight age group that they were premature or low for birth weight babies as well, but a very small group of people, I would say. Otherwise, it is as normal as any other spontaneous conception baby. Now again, when the embryos are not placed inside you, and suppose you already conceived twice, or you tend to have only one child, so what are the options we give you with the leftover embryos? It is totally on the patient, on the couple to decide what to be done by it. The unused embryos, either they can extend for the storage and plan another child after 2 3 years if they want. They can give it for disposal if they don't want it to be used by anyone. Or again, they can uh, give the consent for the research purpose, because there are so many ongoing studies going on, so we really need, so they can definitely do that. Or they can also donate to another couple. Again, it is under the legal parameters, and they won't know who are they donating to. And likewise, the couple also won't know that whose embryos are they taking. It is a very strict law, embryo donation, and they have their own set of rules and regulations which we need to follow. Right. So this is all for now, and if you have any questions, you can ask me. And I think, okay. So there are a few questions I would like to answer. At which age we can use IVF? So IVF can be done. There is no particular age group for the IVF. As I told you, it can be from the age of 20 to 40, 42 also, depending on what is the indication of IVF. So age can be from 20 to 42, not more than 40 and 42 we do it in India. So how many months before we should prepare ourselves taking the IVF cycle? A month is also enough. Again, like we really don't know that if it all is the weight, so then that takes a little longer. You need to shed the extra kilos. If it's the hormones, it depends 1 to 2 months maybe. And if it's only the sizes, then a month is okay. And if it's only thyroid or anything else, so again a month is okay. So yeah, so I would say that depends on the indication and depends on what. Yeah. Then how long does the cycle go on? I would say a month. So it's a 15 days of stimulation and then the transfer in the 2 week period, then it's a month of the cycle, I would say. Uh, what to include in food, exercise during ongoing cycle? Is it necessary to be bed rest at least after 15 days of embryo transfer? Food, I would suggest have more of healthy food, less of fried, less of junk, which is always good. Maintain a healthy lifestyle. Include more of greens, more of proteins, more of fiber in your food. Totally avoid fat, I would say. And yeah, you can obviously include the good fat, and more of greens. Have keep yourself refreshed, have more of juices, have an active lifestyle instead of sedentary, and that can help you a bit. There is nothing direct correlation of the quality of the eggs. They say that if you can eat something which can increase the quality of the eggs, but I would not suggest that there is anything directly, but everything plays a major role. So if you are maintaining a healthy lifestyle, so your blood tests are going to be hormone, your cholesterol is going to be under control, your hormones going to be balanced. So obviously that will fetch you having better quality of eggs, I would suggest, even the better quality of sperm. Yeah. And then someone asked me that is a 15-day period, 15-day rest. Oh, not at all, not at all. That's a myth. As we told you, immobilization immediately obviously helps. And then once the embryo is transferred, there is no way that it's going to fall out. Don't ever panic about it. I have heard a lot many times, especially in our setup also, when they're shifting, when the group D IMers are shifting them from the embryo transfer bed to the normal bed. They're like gentle, it might fall. No, there's nothing like that. It doesn't fall. Once placed, it has to be inside. And so there is no strict waiting period of 2 weeks, but you need to be, as I told you need to be cautious. You need to take your medication on time. The progesterone injections or the tablets or the vaginal tablets which we've prescribed you has to be taken on time. So those basics will really help you. And yeah, no stress. um, all right.